what's up, y'all? I'm Dr. Italo Brown, emergency physician, and this is Med vs. Movie. Now, on the last video, I took some time to break down episode 1 of the new HBO Max series, The Pitt. And like I thought, everybody was going to have something to say. I'm talking about everybody and a mama has something to say about this episode. And I think that the cool thing is that so many people can identify with it, from the entire spectrum of healthcare workers to folks who've been patients before, all the way down to the cinema and film buffs. So, they really got a good one on their hands. But my job is to make sure that the scenes are accurate, the entertainment is educational as well, and at the same time, we get a few laughs off. So here we're gonna do another spoiler alert. If you haven't watched episode 2, I'm telling you right now, stop this, go watch it, pull up, and then we can talk about it all over again. Or if you feel confident about it, you can go ahead and just watch this and then catch it on the back end. All right, so without further ado, let's go ahead and check out some of the scenes that you all told me that you wanted broken down.
23-year-old Ben Kemper, no helmet, got doored riding an e-scooter. Neck versus handlebar, then face planted to the pavement. Obvious facial fractures, but alert and oriented with good vitals.
So in this scene is basically a guy who's a cyclist who had an accident. Super common. People ride bikes all the time, helmeted, unhelmeted, and can have like road accidents where they, hit potholes or swerve to avoid a car and then maybe thrown from their bike. And in this case, the patient was thrown into the handlebars of his bike.
How about now?
Yep. Woo. So they have already decided they're going to intubate this guy, which makes sense to me.
Let's have a look.
Oh, damn. So what's really accurate here is they're telling you the exact medications that are used for the intubation process. And I also think that the view that he's showing you when he's looking with the laryngoscope is 9 times out of 10 what you're going to see in somebody who has a mid-face injury. So earlier they showed him going through the survey. He basically elevated a portion of this person's face. And anytime I see that happen, it's immediately like, yo, what's the airway situation? How soon are we going to have to intubate this guy? Because 9 times out of 10, that area is extremely vulnerable, but also the structures that are deep to that can collapse, can fill with blood, and you'll eventually be dealing with somebody who quickly decompensates. And so right away, you got to get that airway under control. And so they're showing that the cords are swollen. This is probably, not the airway that you desire off the rip.
Yeah, really distorted from the trauma, and the demon's only making it worse.
So IGL bag and Crike, what they're saying here is they're going to put a different type of airway in place, one that will allow them to force air down, and then they're going to prepare the neck to do a Crike. When I was in residency, there was a guy who used to walk around with a 10 blade in his pocket at all times because he was like, it could happen at any moment. And shout out to my dog. But listen, this is highly accurate. I think that what we have to consider in watching this is like, it may not happen all the time, but when it does happen, you need to know the steps and you need to be able to execute, which is why this is so entertaining.
Done a Crike before?
No, Mel will do the Crike. You've already had a busy morning. Glove up, Mel.
No, I'm doing the Crike, doctor.
Surgery want to jump in there and do that Crike. I bet.
ED gets odd days. You know this. For Crike's sake.
It's because you're all fucking odd.
Interesting, right? So they mentioned odd and even days. For those that are like uninitiated to this department, there's procedure days that alternate based upon the service. So she's saying that on even days, surgery gets a chance to do procedures. On odd days, is going to fall in the hands of emergency medicine. So again, microaggressions just bubbling to the surface. Where's all the blood? Where is all the blood? In real life, anytime a Crike is happening, that thing is like the red wedding. I'm talking about, it's blood everywhere. So I'm a little bit like, maybe not as accurate. But I like the steps. I think that every single thing that they're highlighting in terms of the structures involved, the places, the locations to do the incision, and even the equipment that you see, all of this is accurate. This is excellent. I got nothing negative to say about this. I think that everybody can learn from this. Med students, even a few of these folks floating around here who love to manage airways. Like, it's super accurate. I love this. Let's keep it going to the next scene. All right. Now, this is one that people slid into my DMs and specifically asked me to talk about because they couldn't believe the level of exaggeration. And I said, I don't know. Let's see.
Got an unresponsive, unhoused man coming in. Might be a good teaching case, funky music.
I appreciate the language here. That's incredible. Elevating the term unhoused instead of saying someone is homeless, highly accurate in medicine, highly appropriate, and it honors the situation with a little bit more specificity. As a health equity guy, like, I'm always over that. Like, I need that to happen.
Years old, found unresponsive, no signs of trauma, no ID.
Accurate.
On 3. 1, 2, 3.
All right, boss. What's going on here? Oh, see, he said he's smelling. That I can already tell.
Smell the alcohol from here. This guy's wearing the spring, summer, and fall collection.
Oh, damn. Yo.
What's wrong? What's going on?
Hold the hell on, y'all. If you pull up in the emergency department with friends, my man brought the Master Splinter, Templeton, and Fievel all at the same time. This is crazy, yo. But I wouldn't put it past people. I feel like I've seen, support animals in the hospital. I've seen people pull up to the hospital with unwanted guests such as bed bugs and lice. And so it doesn't surprise me when I see somebody, especially if these are not like, just random rodents, if these are actually pets of his, that he would come. Because where else are the pets supposed to go? If he has pet rats and he's unhoused, he don't have cages for them. So it makes sense to me. It's just crazy as an ER physician when we see stuff like this. It's like, as soon as you disrobe a person and then all of this stuff kind of like is there by surprise, it literally takes you to this place right here where they jumping out. Now the bigger concern is why you got 3 random ass rodents running around the hospital. I don't know who's gonna catch them. It ain't gonna be me. This is so accurate. People just be yelling and I'll be like, oh my gosh, she's going down.
Screaming for narcotics nonstop. We found an empty Percocet bottle from 5 days ago.
Why are you calling? He's been uncooperative and combative since we picked him.
Uncooperative and combative.
Stop fighting. Come the fuck down or I'm calling the cops.
Hold on, pause. All right. We still professionals. So anytime I hear somebody that's just like unnecessarily cursing either at the patient or in the direction or vicinity of the patient, at this point you're my patient, and so I don't think that it's far-fetched to check somebody like, hey man, you don't have to say that. Let's use professional language here, or to tell them straight up, sir, I got it from here, you can leave. That's fine. It's clear to me that they are painting a specific picture about this patient, and I want to just see where they're going with it.
Please, I have sickle cell.
Okay, stop.
So
Everybody stop.
Stop!
Exactly.
What's your name?
It's Joyce. It's Joyce.
Joyce, is this your sickle cell pain?
Yes.
10 milligrams of IV morphine.
You really want 10?
Yes, repeat it in 5 minutes if needed. And she needs a dilaudid drip. This is a vaso-occlusive crisis. I'm so sorry this happened. You're gonna be okay now. Okay? We're safe here. Come on.
All right, let's quickly have about a 30-second dialogue about this. First misconception is that patients who are in tremendous amounts of pain are automatically drug-seeking patients. No, in real life, there are definitely several conditions that people live with, chronic conditions that require high doses of pain control. And your job as a physician is to tease that apart. It's like, hey, what do we do here? And once you get to the hospital, I mean, we can treat pain. Like, that's part of our job. And so the discernment comes from knowing the pathology. And so she talks about vaso-occlusive crises, which specifically affect patients who have sickle cell disease. And she's very right and spot on in saying that, like, hey, you can sometimes have a tolerance for these medications, and it requires above average or above your standard doses of medications, because what is normal for someone who doesn't have this is definitely not the norm for a person who is wrestling with sickle cell disease. So the fact that there's like a weird interaction between all of the different providers here, and she kind of has to reaffirm that yes, I'm ordering 10 milligrams of this medication because it's the only thing that will help solve this problem at the moment. And this person is probably significantly in pain. Like, I think that this is a very realistic interaction. And it's sad because, again, this happens all across America where people are going through these exact same episodes and encounter a little bit of resistance once they come to the doors of a hospital. So excellent job at bringing this to the forefront and almost, showing people how they need to navigate this. Dope, super dope. So now in this portion, they're dealing with a patient who was brought in, looks like they got electrocuted. So you're talking about full body, surface burns or some sort of burn. And immediately, now whenever I hear about someone being electrocuted, I'm not thinking like the Looney Tunes version. I'm thinking like, yo, this person it's a countdown until they have some type of compartment issue. This is what we're really taught to catch early because sometimes the signs are a little bit more subtle. And so the fact that they're showing you here that this person is got increased compartment pressures is really accurate. We typically measure them with a device called a striker, and that can help us determine like whether or not the compartment pressure is at a level where we need to do what's called an escharotomy or fasciotomy in this case.
49. Burn caused massive swelling.
What does he need, Dr. Santos?
Fasciotomy, but he still has a radial pulse.
Hitting you with the education. I love it. These bars,
And at that point, he
dropping bars.
Enough to destroy all the nerves and muscles in a matter of hours. Compartment pressure is 49?
Yeah, gonna make the initial incision down here. Ortho can
Yes.
finish up in the OR.
Good plan. I'll let him know. Hey, Robbie.
I think this is crazy.
Hey, like my rock star.
The interaction between, hold on. I just want to bring this back again. The interaction between the two attendings is a lot different. As you can see, more collegial. I love that.
Sterile gloves for Dr.
Go ahead and
Santos.
bust this fasciotomy down.
We don't teach forearm fasciotomies to our residents.
What if she's all alone somewhere someday with no backup?
I agree.
This is the path to avoid the median nerve and all major vessels.
Maybe just watch the first time.
She'll hold the blade.
Now, I feel you. I share that same type of hesitation when I see patients, or rather I see a resident who may have not ever been introduced to something, taking on their first, but at the same time, like, the personnel, you got to realize that like there's a learning element to this. And so, yeah, go ahead and make it happen.
Through the skin and sub-Q.
So the whole purpose of this procedure is to, as I said, relieve that compartment pressure. You're going to make this incision. And as you can see, like, it looks like the tissue underneath kind of breathed a little bit more. And there's a little bit, again, the compartment pressures will be immediately relieved because you've introduced this slit. So highly accurate, excellent use of an entire procedure and showing it in a way that most people never get a chance to hear about.
Savage, classy, bougie, ratchet, sassy, noble, bastard.
Yeah, outside the hospital. I've gone outside and sung songs before too. I got my own little mantras.
Can you guys help?
Yo,
What's your name?
Alex.
yo,
Okay, Alex,
this is so real. I'm not laughing at the situation. I'm laughing because these drop-offs happen all the time, especially in inner cities or places where you have a high degree of like, violence or penetrating trauma. So this is super accurate.
GSW just got dumped by homeboy ambulance.
Wait a
Okay, you
minute.
got this?
Not a homeboy ambulance, dog. All right. I do not condone the use of the term homeboy ambulance. But what she's saying is when the homie drops you off and then they skirt the hell off, it's like a homeboy ambulance. It is considered somewhat derogatory. Again, as I said, I think that this is more of the dark humor that exists within the emergency department that they're playing up in the episodes. So yes, accurate.
2 grams of Ansep, ortho's on their way.
Yup, Ansef, bring it on. The meds are right.
Systolics only 80, 14 gauge.
Again,
left AC.
assume the survey has occurred or is occurring.
The OR will be right up.
There you go, boom. You see her pull out the ultrasound. That's where I'm going, straight to Morrison's pouch.
Morrison's a
Yep.
blood. See that?
Yeah. Torp is liver.
Boom.
his name?
So this is a positive fast, and this is an excellent way to demonstrate the pathway once you get a positive fast.
His name?
Alex.
Alex, you've lost a lot of blood. You need to go to surgery right away.
We're gonna die.
Not now that I'm here.
Yeah, man.
Spoken with humility, Miss Surgery. Boys, ready? How's it doing?
He's coming up a bit.
Let's go.
You call my mom? She's the ice on my cell.
Of course, of course.
Can you call my mama? This is the most accurate part of this whole episode. Can you call my mama? Everybody is hard until they get shot. And I promise you, the first thing that everybody asks is for you to call their mom. But with this said, you know, like, I think that this part is very, very accurate. Everything from the drop off to them rushing him into the trauma bay, doing the assessment, bringing out the ultrasound for the EFAST, and then immediately diagnosing a positive FAST within the Morrison's pouch where you see this gunshot at. And so this patient is going immediately to the OR. There's nothing else to do except you have to do the exploratory laparotomy or an X-lap to identify where the bleeding is coming from, where the pathway of the bullet is, remove any type of foreign objects or shrapnel that you can. If there is damage to the internal organs or the bowel or the visceral, you know, you need to make sure that this is all handled surgically. So this is accurate as it gets. Man, I packed a lot in this episode. I know I try to give you as much as I can without giving you the full episode in one, but I promise you they are getting better and better as it goes. And I think that's just how the shift is in general. When you get that next hour, more things happen. So it only makes me even more excited for what's to come in the following hours. Accuracy level on this one, I'd have to say it's at a 9. Like, every single procedure seemed to be very well thought out and explained, and they show you visually what's happening. I think that this is very good attention to detail. And then finally, the random things that occur from a patient who has sickle cell disease screaming and being mistreated by whomever is there, having to have a provider come in and basically advocate on her behalf, all the way down to rats popping out of somebody's jacket when it's pulled down. All of that happens in the emergency department. And so I just am super excited about the trajectory of this series. And it also makes a lot of us feel seen. So salute to you. Keep them coming. If you got questions, you know, you can throw them in the comment section or shoot me a message. I love it. If you want to see more videos like this, make sure that you like, subscribe, and follow Med vs. Movie. All right, y'all. Dr. Italo Brown signing out.